First, I want to say thank you to Swapna for opening things up today. Always a strong, positive message, and we thank you for that. And thank you to Oley for inviting me to speak today. I appreciate that so much and truly honored to be here and to speak to the short bowel community. The title of my presentation today is Diet and Medication Strategies to Reduce Diarrhea in Short Bowel Syndrome. And let me just be sure I can, and for disclosures, I just want to say that I'm an employee of OptumRx. So the main objective is for consumers and their caregivers to learn the key diet and medication strategies to help reduce diarrhea, to improve intestinal absorption, minimize dependency on both parenteral nutrition and IV fluid, and most especially improve quality of life. Just having a little trouble with the advancing part. Let's see. Sorry about that. Let me just see if I can advance.
Maria, if you click on the PowerPoint itself and then use your right arrow, it should go forward.
Okay, thank you.
No, just left click on the PowerPoint and use your right arrow on your keyboard.
Okay, I'm doing that. Shoot. Oh, you know what? I think I'm good. Oh, maybe not. What is happening?
Would you like me to share your presentation?
Would you? That would be just so fabulous.
Okay.
Okay, great. Thank you so much. Okay, we'll pick up from here. So just as a reminder for the audience, that short bowel syndrome is a specific type of intestinal failure that occurs because of a loss of significant portion of the small bowel's absorptive area. It was initially defined as having less than 200 centimeters or 6.5 feet of jejunum ileum in continuity after bowel resection, but we've really moved away from that definition. It's currently defined as the failure of the intestine to adequately meet the nutrient and fluid requirements of the individual. And it is the most common type of chronic intestinal failure and can occur in adults and children. Next slide, please. So diarrhea is the primary consequence of short bowel, leading to major fluid and nutrient losses, incomplete digestion and absorption of food, and certainly can have a negative impact on quality of life. When left untreated, dehydration, electrolyte abnormalities, vitamin and mineral deficiencies, and progressive weight loss and malnutrition can occur. So the need for nutrition support to prevent dehydration, to stabilize electrolytes, avoid weight loss or restore weight, and to provide vitamins and minerals is certainly significant. But the severity of short bowel is determined by the length, location, function, and the adaptation of the remaining bowel. So everybody's nutrition plan looks a little bit different depending upon those features. Next slide, please. So diarrhea is the key feature of short bowel, specifically because of the significant absorptive area that is lost, either due to intestinal resection or due to loss of function. And this loss of intestinal absorptive area leads to rapid transit in the bowel, and just food and fluid is going to move quickly through a shortened length intestine. Also, it leads to hypersecretion of stomach acids, and that's because this mechanism that usually turns on and off with eating stays on all the time, especially for the first couple of years, or at least for the first 6 months following surgery. Next, what can occur is bile acid deficiency for those that have had greater than 100 centimeters of ileum in particular removed. And this can lead to steatorrhea or diarrhea with a lot of fat in it. And that's not in all patients, but it certainly is in a good majority. And for some, this can also lead to bacterial overgrowth, especially for those with colon remaining. Next slide, please. But it's really important, although diarrhea is a common feature of short bowel, we just also need to be sure that we're not blaming everything on the short bowel and that all other causes of diarrhea are consistently being ruled out. For example, for those with active underlying bowel disease, an inflammatory bowel condition like Crohn's, for example, it's possible that the Crohn's is flared up and that could be contributing to a change in stool output. Medications, really all medications potentially have the possibility of causing diarrhea. So it's important to routinely look at medications and specifically the ones that are in the liquid form to be sure that there's no sugar alcohol, which we'll talk a little bit more about, and making sure there's no infectious source of diarrhea. It's not uncommon to spend time in the hospital as a short bowel patient, and it's possible to pick up new bacteria. Specifically, we often see Clostridium difficile as an infective source of diarrhea that can be treated. So just wanted to be sure that we're always thinking about that as well. Next slide, please. So when we think of interventions to control diarrhea, we think of a couple, and the two that I'm going to focus on today is both diet and standard medications. And these two strategies are part of a bigger strategy called intestinal rehabilitation, which is a collection of interventions that can be used alone or together to promote bowel adaptation, resulting in less diarrhea, better absorption of fluid and nutrients, leading to better quality of life and hopefully less IV nutrition and fluid requirements. So let's go forward with talking about diet modifications. Next slide, please. Okay, so there are two diet prescriptions that you most commonly see related to short bowel and as part of the management. So although the principles remain the same, extensive research has demonstrated that consumers with a colon need a different percentage of nutrients than those without a colon. So as you'll compare in the table, those with a colon should consume a diet higher in carbohydrates, that's 50 to 60% of total calories, with limited simple sugars, lower in fat, so 20 to 30% of total calories, with a limited number of oxalates divided in 5 to 6 meals per day. Whereas those without a colon should consume a diet just somewhat lower in carbohydrates, so 40 to 50% of total calories, with restricted simple sugars, higher in fat. So that fat content should be between 30 and 40% divided in 4 to 6 meals per day. You'll see in both diets that the protein is the same, 20 to 30% of total calories. And isotonic fluids are recommended, and we'll talk about that in a moment. And soluble fiber can be used if stool output is not well controlled and gets to be above 3 liters a day. But I want to just explain the differences a little bit more in detail, especially around carbohydrate and fat. The reason we recommend more total carbohydrate for those with a colon is because patients with a colon often have shorter segments of small bowel than those with NJ genostomies and therefore have higher calorie needs. And a high carbohydrate diet can help meet those higher calorie needs through a process called colonic fermentation. And this is when malabsorbed carbohydrates enter the colon and the bacteria in the colon feed on that and create short chain fatty acids that are absorbed and then utilized for energy. And so this process just simply can't occur in somebody without a colon. So there's no reason to push the carbohydrate calories up to that 50 to 60% mark like we do for those with a colon. Now, the reason less fat is recommended for those with a colon is because when more than 100 centimeters of ileum is removed, as I mentioned just a moment ago, bile salts, which are needed for fat absorption, are really malabsorbed in large amounts, and eventually those bile salts get depleted. And when fewer bile salts are available, limiting the absorption of fat and fat-soluble vitamins, we end up developing a secondary problem in which calcium ends up getting bound up and not being available to bind up oxalates. And those oxalates pass freely to the colon and then get absorbed and can contribute to kidney stones. So we really want to be careful with the fat so that sequel doesn't occur. And with someone without a colon, that is not a worry or a concern at all, since all of that cannot happen. So we actually push the fat a little bit more in somebody without a colon and don't think about the oxalates. Okay, next slide, please. Okay, so to be able to talk more specifically about carbohydrate, we really need to talk about this rather big word. Takes us all back to our chemistry classes, but osmolarity. So it is the number of osmoles, or the number of particles per liter of solution. More simply, it's concentration. And so the more particles there are, the higher the osmolarity, or the concentration. So why is this important? Simple sugars in food or beverages cause an increase in the concentration of intestinal fluids due to their very small particle size. And this can result in diarrhea, malabsorption, loss of fluids, electrolytes, and vital nutrients. So I want to talk about this as it relates first to beverages. So next slide, please. So there are three types of fluids. There are hyperosmolar fluids, and these contain many particles of glucose in little to no sodium. That the result of that is that they cause fluid to be pulled into the intestinal tract to dilute the concentration of the drink, causing watery diarrhea. So examples would be juice, soda, smoothies. Hypoosmolar fluids contain few to no particles of glucose and no sodium, so they're not concentrated at all. They're not always absorbed entirely. They're known as free fluids. So beverages such as water and decaffeinated and sugar-free beverages are examples of an hypoosmolar fluid. Iso-osmolar fluids contain sodium, potassium, and glucose in the same concentration as blood in the extracellular fluid. So they will not cause fluid to shift into the GI tract, and in fact, they will actually get absorbed quite well. And examples of these are our oral rehydration solutions. So next slide, please. So to really drill this point home, I want to just talk about it for a little bit more by just explaining that the reason we focus so much on that concentration is to best understand this. I want to explain that the fluid that surrounds the GI tract has a concentration of 275 to 295 milliosmoles per liter. And when you look at each of the categories here, when we talk about hyperosmolar fluids, these have anywhere between 550 to 1265 milliosmoles per liter. So that number is so much greater than the concentration of the fluid surrounding the GI tract that results in order to dilute that highly concentrated sugar within the GI tract, it requires fluid from outside the GI tract to come in to the GI tract to dilute it. And as a result, that can cause a significant diarrhea very quickly. Now, this process is occurring in all of us, but when you have, feet and feet of bowel for this to sort of settle out in, there isn't necessarily a consequence. But when you have shortened length of intestine, there can be quite significant consequence. So this, if there's nothing else you would walk away with today, is this one point that the concentration of what you eat as well as what you drink matters quite a bit. Next, with the hypoosmolar fluids, as I mentioned, they have very little concentration, and as you can see, quite quite a bit less, 0 to 18 milliosmoles per liter as compared to the 275 to 295. So they are not causing fluid to pull into the GI tract, but they're not getting really well absorbed. And what we find most commonly with our consumers is that when water, for example, is consumed in large amounts, it tends to not get very well absorbed and often moves through not quite as quickly as the hyperosmolar fluids, but often not well. It doesn't get absorbed well, and can cause a fair amount of diarrhea. So it's the iso-osmolar fluids that match the fluids surrounding the GI tract. And those are our oral rehydration solutions. And the examples that are given here specifically from this reference allow us to see that it really matches, from the Cerolite 220 up to, the Gatorade of 380, kind of within that range. There, pretty much matches the concentration of the fluid surrounding the bowel. So let's look at iso-osmolar fluids a little bit more. So they are the beverages of choice for short bowel consumers. They contain, the sodium, potassium, and glucose in the same concentration, again, as the blood plasma, and they do not cause fluid to shift into the GI tract, helping to minimize stool output. An important note about these drinks is that it's important to drink an appropriate volume of them slowly throughout the day, and not, just like, oh, I've got to drink my special, oral rehydration drink and drink it in a short period of time. So just as important as choosing the drink is making sure you're drinking it at the right pace. So let's look at some recipes on the next slide, please. So there are some commercial products such as, and you've heard me say some of them already, Cerolite, Drip Drop, Pedialyte, Rehydrolite, the World Health Organization's commercial preparation that Janus Brothers puts out. And then the World Health Organization has since come out with a reduced osmolarity formulation, and that has been manufactured. One of the companies that manufactures it is in the format of a tri-oral product. And that is available for patients, kind of ready to drink or as packets to mix just with water. Some prefer to make their recipes at home. Either there's the G2 recipe that Swapner referenced, and there with that you would take the 4 cups of G2 Gatorade and mix it with a half a teaspoon of table salt. You can also make a fruit juice based solution with 3/4 of a cup of a fruit juice, 3 1/4 cups of water, and 3/4 of a teaspoon of table salt. So this is just really scratches the surfaces. There's many recipes out there, but the importance, what I really want you to walk away with is understanding the science behind why this would be an ideal choice for somebody with short bowel, and it all relates back to concentration. Okay. So when we speak of diet, the short bowel diet really emphasizes complex carbohydrates and restricts simple sugars, both in foods and fluids. And it's just so very important to account for all sugar all throughout the diet, really all day long. So looking at both the sugar that's coming from the beverages that you're drinking, as well as the food that you're eating, in order to be able to compensate for the shortened bowel length. The short bowel diet should contain a source of complex carbohydrate, protein, and fat, especially essential fat at each meal and snack. And just as important as spreading the fluid out through the day, we want to be sure that you're distributing food throughout the day as well. And we want to restrict fluids at mealtime in particular to 4 ounces, and be sure that fluid is hyperosmolar or isotonic. And really the majority of the fluid should be isotonic throughout the day, but some people do need breaks from the rehydration solutions. And so typically, if you're looking for a break of having a little bit of water, we recommend doing that at mealtime, or slightly after mealtime if you're trying to separate your fluids with your meals, and doing 4 ounces at a time. Next slide, please. So how do we deal with this? I mean, obviously, there's, everybody's got a little bit of a sweet tooth and some more than others. How do we deal with reducing the sugar without sacrificing all the time? And so the way to get around it is the alternatives to sugar. But it's really important to note there's a big difference between two different types of sugar. So in this category, non-nutritive sweeteners are intense, very low calorie sweeteners that do not have an adverse effect on stool output, since they do not contribute to the osmolarity in the GI tract. So these sweeteners can be used as an alternative in order to reduce simple sugars in the diet. And these are all examples of products on the market that would meet that guideline, that basically you can consume them without it having a negative impact on the GI tract. So there's ways to use these products to sweeten beverages. There is many of these products you can cook with so that you can make desserts with that are lower in sugar. So these are very really prevalent in the marketplace and available for our this population as well as a diabetic population, which they're often marketed to. Next slide, please. The important thing to note is that there is another alternative to sugar called sugar alcohols. And these are used also as low-calorie sweeteners, but unlike the non-nutritive sweeteners, they are designed to be malabsorbed in everybody, causing uncomfortable side effects like abdominal gas, bloating, and diarrhea. And those are certainly not symptoms that any short bowel patient is looking to have more than they already have. So you really want to be on the lookout for sugar alcohols and avoid them. They can be found in the ingredient list on food labels as really anything ending in ITOL. We see them as sorbitol, mannitol, and xylitol most commonly. And a product labeled sugar-free must contain a separate line for sugar alcohols under the carbohydrate section of the food label. So you will see here, for example, it would be delineated right on the label itself, and then those sorbitol, mannitol, xylitol would be in the ingredient list. So you absolutely want to be on the lookout for these, and also know that these things are hiding in sugar-free gums, in candies, mints. So, I know people often struggle with dry mouth and lean on those types of products. And you just want to be aware that they're often in those products, and there's a cumulative effect of that, having, multiple pieces of gum or mints or that sort of thing. So just to be aware of. Next slide, please. Okay, so switching gears just a little bit, and I preface this next section by saying that I am a dietitian, as I have said at the beginning. And this is not exactly my area of expertise because I'm not a pharmacist. I'm certainly not a physician, but we spend a lot of time as dietitians focused on this because the diet can't work alone. And what we often find is that patients have tried antidiarrheals and are not always super successful with them. So what I find when I'm working with a patient is that they're often underutilized. A patient may have started it and then stopped it because they didn't think it was being effective. So it's really important to understand that basically, if these medications were trialed at a time when no diet instruction was provided, an inappropriate diet can negate the effects of an antidiarrheal. So really, it's so important, and why I'm emphasizing it in today's talk as we are trying to reduce diarrhea, to revisit the medication piece of things and be sure that if you're making changes to the diet, that in conjunction with those diet changes, really you want to take a fresh look at standard medications, things like antidiarrheals and anti-secretories in order to help to control symptoms. So when we speak about antidiarrheals, they are used to increase intestinal transit time. So their job is to slow down the GI tract by helping to increase absorption of nutrients. Examples of these in first-line therapies are things like loperamide or Imodium and diphenolate, which is Lamodal. So these both of these act by slowing intestinal motility. and by affecting water and electrolyte movement through the bowel. And they're, really the starting place, and these are medications that should be maximized before considering second-line therapies such as codeine, tincture of opium, any of the narcotics, which can be quite beneficial in helping to decrease stool frequency, but come with some side effects and are not always pleasant side effects. So we want to be sure that we're thinking through the anti-diarrheal sort of in a stepwise fashion. And in addition to noting that these doses have to be adjusted often, the timing in which they're taken is also really important. So they should be taken 30 minutes prior to meals for maximal effect. You want to be avoiding liquid forms of these medications because they are usually typically higher in sorbitol, and the dosing really varies. So I just, that I don't want to, stare you down a path on that without you referring you back to your medical team. But it is possible that you may need a dose that exceeds package dosing. So it's important to really, drill down on this with your team and know what is right for you based on your bowel anatomy. Next slide, please. And anti-secretories are also really important because they're used to decrease stomach acid secretion, which is, as I mentioned before, increased after bowel resection. So there are two types of anti-secretories most commonly used. There are the H2 blockers, which are histamine H2 receptor antagonists. And all that means is it inhibits both acid concentration and volume of acid secretion. Products like famotidine and ranitidine, or Pepcid and Zantac, fall into this category. And these products are available both orally and can be added to parenteral nutrition. So that's something to note. Whereas the proton pump inhibitors, these block the final step of acid production. Examples such as Prilosec, Nexium, and Protonix. The Prilosec and the Nexium come in oral dosing. The Protonix can be given intravenously, but can't be added to TPN. So what we often find is, although the proton pump inhibitors are highly effective and are considered first-line treatment, it's sometimes hard to give it intravenously because it requires a separate infusion. So most routinely in home nutrition support, we find Pepcid being used most routinely. So the dosing can be daily, it can be as much as twice a day, and often we see it prescribed both orally and intravenously to cover the full 24-hour day. And best practices, these medications are typically necessary after significant small bowel resection for a period of time of up to 6 months. But long-term use will depend on individual symptoms and underlying disease process. So although we say at least 6 months, it's really important to note that it is possible you may be someone that needs these longer. Next slide, please. Okay, so I mentioned these additional medications just to be aware. These are not standard. Everybody should be on these medications if you have short bowel, but I mention them because if the diarrhea is not improving with diet manipulation and standard therapies like antidiarrheals and anti-secretories, these are medications that we see often added. Medications like octreotide, also an anti-secretory, helps to control stool output, but really should be given when a patient really exhibits signs of what we call a secretory diarrhea. And by that, we mean diarrhea that occurs even in the absence of eating. When you're eating and drinking, we expect you to have output, and that's because of this osmotic effect that I've described earlier. But if you're not eating and drinking, the output should go down dramatically. So if you're questioning whether you may have a secretory diarrhea, not eating and drinking for a 24-hour period and measuring your output would help answer that question. And typically we say output greater than 800 mLs per 24 hours is considered to be excessive and more indicative of secretory diarrhea if you're not eating and drinking. Cholestyramine is a bile salt binder that can be used in short bowel patients. As I mentioned, The ileum often is more than 100 centimeters is often resected in a short bowel patient. So the bile salt pool is often depleted. So it's often not necessary to add a cholestyramine because there's no bile salts left over time to bind up. But there are a subset of patients that complain of rectal burning with early morning stool where they may benefit from a cholestyramine. So it's really important to be aware that that medication is available and may be beneficial if you're someone that falls into that category of symptoms. I mentioned bacterial overgrowth for patients that are, have their colon and are prone to chronic gas and bloating. That's not resolved with sort of typical diet management. For those patients, antibiotics on a possibly rotating basis may be necessary. And then there are pancreatic enzymes. Now, this is not something that's typical, but acid hypersecretion can lead to the inactivation of pancreatic enzymes. So rapid transit doesn't always allow for food and enzymes to mix together. So although short bowel is not, it's a malabsorption problem, not a maldigestion problem, it can be that because of the rapid transit, the pancreatic enzymes are not ending up in the GI tract quite at the right time. And if that's happening, there may be a role for pancreatic enzymes. So I'd like to mention that as a potential to add on if the diarrhea is not improving. Okay, next slide. So where do we go from here? Kind of what can you walk away today with to sort of see if you can make a change in your stool output? So it would be great for you to start by writing down what you're eating and drinking for 3 days. Note the number of times you have a bowel movement or empty your ostomy. Review the medications that have been prescribed to control your diarrhea to ensure you're taking them as prescribed. And then you kind of want to pause and review this information with your team to see, kind of where you're at and what might be recommended next. Next slide, please. And then you may want to consider adjusting your oral fluid choice based on the things we talked about today, making one significant diet change. I really focused on the sugar today and in the carbohydrate category as it relates to both food and fluid. And that may be one kind of hard, area within the diet to look at. Sugar comes from a few different places, and even sugar from natural sources. We're in the summer months, and I live in the New England area, and it's strawberry season. So, just taking a hard look at even your fruits, because although you may not be thinking about those, you may be thinking about limiting dessert, so to speak. It's sugar from any source. Your intestine doesn't really discriminate between whether it came from a healthy source like a strawberry versus from ice cream or some other yummy tasting smoothie or vanilla shake. It is really just important to note that sugar is sugar, and the way the bowel sees it is the same every time. So I want to, really emphasize that point, and be sure that you're committing to the medication regimen that's been prescribed to you. Asking questions around that and possibly getting modifications to that regimen if anything that you heard today might be helpful to you, because these are the standard things before we go on to thinking about other interventions. And as I mentioned, diet and these standard medications are just kind of step 1 and step 2 as part of intestinal rehabilitation. There are many other options, but we want to make sure that you've addressed the basics. And that's what I hope I've done today. And I appreciate your time, and I'm looking forward to answering questions at the end of today's session. Thank you.